I hope
Okay,
that everybody
so
can see the slide now.
yeah.
Yeah, okay. We go next then.
So we will start by this history of physiology that Upendra has described, but it's good to see in visually. When I left the university, Jung was the equation to measure the pressure gradient in the coronary artery. Fortunately, Lance Gould in 1978 became much more pragmatic, and he said the gradient delta P is a function of friction and separation of the laminar flow, and friction is a function of velocity. Separation is modified also by the velocity and the length of the lesion. And then another cardiology, Kirkcaldy, popularized that concept. In 1988, I get my hand on the velocity Y and start to do some flow velocity validation. In 91, a Swedish cardiologist, because the pressure Y was initially from a Swedish company, Radi, joined us in the Thorax Center, and then we did a lot of work creating the stenotic flow reserve concept, and then I combined the pressure Y with the velocity Y, and we made the complex physiology in human being with Carlo Di Maio, which was in my lab at that time, and finally a single Y was created with the pressure and the velocity. Yes. Now, what is important, as Upendra has said, is that in 1996, Nico Pels, Bernard de Bruyn, and William Wentz published the concept in the New England of the fractional flow reserve. They did the DEFER trial, which was the first trial, has now almost 20 years of follow-up. And then in 2009, FAME, FAME2, and FAME3. And then Justin Davis simplified the principle in 2011 with the IFR, Advise 2, and Syntax 2. That's trial we have been participating in. And then in 2017, we had the big outcome trial, IFR. I was the chairman of the Define Flare, but it was the Sweetheart, and then the Syntax 3. Now, in parallel, yes, in parallel, we developed a trial, we conduct a trial with the flow reserve, coronary flow reserve ERA, debate 1, debate 2, Destiny with Antonio Colombo and Prost. And then in connection with the Stanford University, I was interested by the shear stress, and we combined angiography and IVUS, we call that Angus, and then we moved to the shear stress, which became quite complex, yes, with up to recently non-Newtonian pulsatile shear stress with very catchy, colorful pictures, yes. Looking at the shear stress in patient and looking at the absorb technology. But after that, yes, what happens is that suddenly Charlie Taylor from Stanford developed the FFR-CT, and that was based on complex Navier-Stokes equation and computational fluid dynamic, a series of trials, Discover Flow, de facto, NXT trial, platform, Syntax 3, and that emergence of the color code and 3D angiography stimulate again the conventional fluoroscopic technique to create a 3D angiography, and in combination with the TIMI frame count to have some pseudo, I would say, computation fluid dynamics, either using the Lance-Gould equation of the Navier-Stokes. And at the bottom of this slide, you could see what maybe will come in the future, which is going back to the past is that on top of the color-coded quantitative flow ratio with angiography, we could have also the coronary flow reserve with video densitometry and the technique of angiography. Next slide. Now, I don't have to talk too long about that, but what was important is that differ demonstrate that there will be no benefit of stenting in a non-ischemic stenosis. And what is amazing is that we are now 15 years later, and as you could see on the right-hand side in defer, the rate of event is 2.2% after 15 years. So 5 years follow-up and 15 years follow-up has demonstrated that you can defer the treatment of a stenotic lesion not flow limiting. Next slide. And at that time, the criteria was the FFR 75. Then came FAME1 and FAME2. FAME1 was FFR guided PCI result in fewer stent and fewer event compared to angio guided PCI. Very important message, complemented by FAME2, where the FFR guided PCI with medical therapy was superior, improved the outcome of the medical therapy alone. Next. Then, as we mentioned, there was this fractional flow reserve necessitating the administration of adenosine to create hyperemia, but then Justine Davis introduced the IFR, which does not need the reactive hyperemia. There was a big debate, is one better than the other? I think the Sweetheart and the Defined Flare show that in terms of outcome, at least at 1 year, it was very, very similar. And thus the IFR came very quickly in the European guideline. Next slide. Now, if we look at the guideline of 2018, European Society of Cardiology and AACS, what is required as a proof of ischemia? In the left main, and everything is 1A, recommendation class 1, documented by randomized trial. In the left main disease, in the proximal LAD, in the 2 or 3 vessel disease, in the single remaining patent coronary artery disease, in hemodynamically significant coronary stenosis, in the presence of limiting angina of angina equivalent with insufficient response to optimized medical therapy, you should, yes, document ischemia. Next. And prove the point by FFR of IFR, FFR 0.80, IFR 0.89. That was in 2018. Next. Now, what was more specifically as recommendation on functional testing, in the same document, it was said, and that was a 1A, that when the evidence of ischemia is not available, so you're going to the lab without anything, exercise testing, PET, thallium scintigraphy, then FFR or IFR were recommended to assess the hemodynamic relevance of intermediate grade stenosis. And then the FFR guided PCI should be considered in patients with multivessel disease undergoing PCI. Next. Yoshiruma, any? Okay, good. So in 2019, then the guideline became even more simple. If you have angina symptom, If you don't have a China symptom, you have, of course, to document the ischemia. And then if the thallium scintigraphy, for instance, is not symptomatic, is not significant, next, you have to do an FFR of an IFR. If the angina symptom is there and you don't have a positive thallium scintigraphy, then you have to do an FFR or IFR. And then in multivessel disease, even if you have a positive thallium scintigraphy, the yes, for identifying the lesion that you have to treat, you have to do an FFR and an IFR. Next. Now, that was for the past. Why the FFR is not widely adopted? There is the following limitation: prolonged procedure time, additional cost, discomfort of side effect from drugs, the adenosine, heterogeneous effect of hyperemic agent. I mean, initially we use papaverine, adenosine, there is other analog, and then some mistake in the measurement, in the pressure measurement. You may have up to 1/3 of the case in the literature where you have a pressure drift, an aortic pressure ventricularization, an aortic waveform distortion. So it is not so simple. And then it's obvious that this pressure Y does not have the quality of the normal Y, so sometimes it is difficult to negotiate a vessel with complex anatomy. Next. Now, this is what we have today. On the left-hand side, you have the classical hyperemic pressure ratio, the so-called FFR, with as a criteria 0.80. Then you have a family of non-hyperemic wire-derived pressure ratio in green on the whole cycle or in the diastolic subcycle. And as you could see, we start with PDPA, but then you have DFR, IFR, AFR, DPR. Each company, Boston Scientific, Philips, Abbott, and Obsense, have created something. That's for the pressure Y. In red, you have the angiography-derived FFR. Basically, today there is 3 companies well established in the field: Medis with the QFR, CatWorks with the so-called FFR angio, and P Medical with the virtual FFR. And then on the left-hand side in blue, you have the multi-slice CT scan, and that's the FFR CT of heart flow. Now, let's look at the next slide. I mean, we have been involved in that field very early. If you look at the right-hand side, it's a publication in the Eurointervention. As you could see, a lot of people from Harvard and Greece, Iona. I'm the senior author. We use the Lenz-Gould equation. And then on the right-hand side, you have Hans Reiber working with one of his mentoree, Sendian Tu, and William Wentz, and you use the Navier-Stokes that was published in JACC Intervention, basically the same year in 2014, as you could see at the bottom of the slide. Next. Now, this is the 3 system, the QFR of Medis, the FFR angio of CatWorks, and the VFFR of P Medical. They are all CE mark available. All 3 need 2 projection, 25 of 30 degree separated. The QFR is a mathematical formula, the Lenz-Gould. The FFR angio of CatWorks is a little bit more mysterious. I mean, it's difficult to find a clear description of what it is. It's still an IP well protected. And then the VFFR is also based on Lenz-Gould. The QFR has been the most published technique with Favor Pilot, China, Wi-Fi 2, etc. The FFR has been used by Bill Ferron, a great man in the pressure Y technique, but now he has fully adopted the so-called FFR angio in a trial published in Circulation called FAST FFR. And then you have, again, in neurointervention, the demonstration of the validity of VFFR of P medical. As you could see, the area under the curve for prediction of FFR less than 0.08 is very high, 92, 96, 94, 93. The time we will review that with Yoshi can be 5 minutes, can be 2.7 minutes. It is not described in the VFFR. Next. So what we did is 2 years ago in the European Heart Journal, we tried to review the diagnostic performance of angiography-derived fractional flow reserve. And we made a systematic review of the literature and the Bayesian meta-analysis together with Yoshi, second author, myself, and William Wine and Bernard de Bruyne. Next. And you see there were at that time 14 studies already published. You have the technique of the different technique which are illustrated, but we reviewed these 14 studies. Next. And you have the detail of the technology. Some is MADIS, some is virtual fractional flow reserve of P medical, some are FFR angio. You see the number of patients and the principle of the analysis and the reference standard, which was most of the time FFR with IV adenosine of IC adenosine, and you see the threshold used for the comparison. Next slide. We can go very quickly on that. We did an analysis of sensitivity and specificity, positive and negative likelihood. Next. And we came to the conclusion that the sensitivity of the angiography-derived FFR was high, 89%, specificity 90%, likely positive likelihood 9.05, negative likelihood ratio 0.12. Next. And you see here the area on the curve. In the top of the illustration, you see a typical area under the curve. You know that if you have a very good sensitivity and specificity, it will be like the blue line. The red line is already a little bit less, and the green is not satisfactory. And as you could see, we look at the mathematic formula of the CFD, and the shoulder of the area under the curve is very high for the method for pressure drop computation. It's also very high, doesn't matter if you talk QFR of MEDIS, of FFR angio, of CatWorks. The software give you very similar result. And then if you do online or offline, it doesn't matter. In conclusion, in that paper with Collet, Yoshionuma, and myself, no difference in diagnostic performance between type of method for pressure drop computation, software, or online, offline analysis. Next. So we are getting close to the pragmatic stuff after this introduction. Basically, what you have to do is two projections separated by 30 degrees. These two projections will facilitate the 3D reconstruction. Then you have to look at the frame count, the arrival of the contrast medium frame by frame in the coronary artery, and the combination of these 3D reconstruction and frame count will give you the quantitative flow ratio color-coded, and when you go below 0.8, you go from the blue to the green to the yellow, etc. The CatWorks system is a little bit similar. 2D angiography, 3 model reconstructions, stenosis assessment, and color-coded assessment of the QFR. Next. Next. Yeah, that's just an illustration. That's also how you do in the lab. You can pass that slide. And then the technique of P-Medical, again, very similar. 2 angiograms separated by 30 degrees. Pressure drop is calculated on 3D reconstruction, and you have the color code assessment. Next. Last point for me is the online versus offline. That's very important, that what you do in the lab is indeed confirmed by a core lab who has more time to analyze everything. And you see that in favor too from China, in this trial, the online or the offline give you very similar result with a good accuracy, 92.7 and 93.3. Next. That's my last slide for the first part. Impact of QFR on clinical outcome is still under investigation. It's a field which is progressing very quickly. The trial in China is already completed, and the European-Japan trial is making progress. So in the European-Japan trial, they are looking at QFR versus FFR, what we have done in these meta-analysis, but now it's randomized. And in China, they are looking at QFR versus the current practice, the standard of care. That's a superiority study, and it's also randomized. Next, can hear you.
Okay, so my part is about the QFR in a patient with the complex lesions such as left main or 3-vessel disease, and also to talk about the planning based on the FFR. So this is the a sub-study of the Syntax 2 trial where we enrolled the patient specifically with the 3-vessel disease. And of course, in this trial, as a part of the selection of the patient, we calculated an anatomical syntax score together with the Syntax 2 score. But we also look into the functional syntax score, which is the kind of addition to the anatomical syntax score. You do the IFR or FFR or QFR to look into the significance of the lesions observed in the angiography, and in this case, we use a QFR to calculate the functional syntax score. And in this particular case, you can see that there was some lesion in the right coronary artery, but the QFR shows the negative result in the distal part of the RCA 0.92. It is the same QFR 0.98. Circumflex has a significant drop in the QFR 0.62. So we keep this point, but we waiver the point from the RCA and LAD. So after incorporating the functional aspect, in this case, syntax score became reduced from 27 to 9 points. So these are the QFR and the comparison between the QFR-based functional syntax score and IFR, FFR-based functional syntax score. In the trial of the Syntax 2, we also have a routine measurement of the IFR, so we could calculate the functional syntax score based on the IFR, and we also look at the functional syntax score based on the QFR, and it shows at a very similar number. Based on QFR, the functional syntax score is 14.8 points, whereas the functional syntax score based on the wire-based measurement was 16 points. So we show that it's feasible and it's reproducible compared to the invasively wire-based functional syntax score. This is just to show that how we actually do the analysis. So we need 2 projections, which should be the separate projection by greater than 25 degrees. You see these LAD regions, you have 2 projections. Then we do the normal QFR, QC analysis. you can push this button of the QFR analysis, and then we are going to do the QFR analysis. So for these two projections, we need to have a common point to merge the two projections, making into the combined into the 3D model. So we have to put this corresponding point. In this case, we selected the bifurcation point between the LAD and diagonal branch, so that we are sure that these points are the same point in these two separate projections. And then you see this center line and trace of the vessel wall. Sometimes you have to a little bit correct the edge detection of the lumen border by the software, but it's not really significant changes. Yeah, in this case, we have to change a little bit in the two points, but it was kind of a semi-automatic correction of the edge of the LAD. And then we can merge these two projections, and in the end, it creates the 3D model of LAD in this case. So we can also look into the different angles, and this is the 3D model based on these 2D projections. And then after that, we have to measure the flow of the coronary arteries. So we look into this frame count, see the timing where the contrast is touching to the vessel wall, and frame where the contrast is the reaching to the distal point. So this is a start point and distal point, and we will count the number of the frame in between. So start frame in this case was 7, end frame as a 15. So they will automatically calculate the flow of coronary artery, coronary flow, and then it will be calculated into the QFR. So the 3D model now becoming QFR, and you could really see the pullback of QFR as like a pullback of the FFR. So this study, in this case, it's a significantly drop of QFR, and proximal part is 1, and you see that there was a significant drop already in the proximal part, and there was a gradual drop of the QFR in the mid to distal part. And in this case, that the distal QFR is quite significant, 0.46. So if you look at the output of this QFR, you can see that first of all, there was a diameter curve from the two projections, and there is the QFR pullback parameters. And if you look at these parameters, vessel QFR is the QFR in the distal part of the this analysis. Lesion QFR is the between this green part is the lesions, and that's 0.46. And index QFR is the QFR of any selected point. So you can move this QFR point, and you can really measure the along this pullback what is the QFR of the certain point of a coronary artery. And this is an assumed QFR after the treatment of lesion. So we just touch upon later the planning based on the QFR, but you can really predict the residual vessel QFR if we treated these lesions. So if you stent these green parts, the QFR will be simulated as a 0.99. So the this is next case is a case example from the Syntax 2 trial. So we did the 3-vessel QFR. Of course, it takes some time because you need to do this QC analysis of the 3-vessel. This is the LAD lesion. You can really see that some kind of a tight lesion in the LAD. Circumflex also has the another lesion, which is a little bit intermediate, but this obtuse marginal has some lesions. And we do this two projection, and I think for the 3-vessel, it's very important to have a good 2 projections at least 25 degrees apart, and that's some challenge we had in the Syntax 2 because it was not really prospectively acquired. So we did a retrospective analysis. So the analyzability was somewhat limited because of the availability of 2 good projection of each regions. So in this case, we could do this tracing of the vessel wall in the 3 regions, right, LAD and circumflex, and by combining these two projections, you can have this 3D reconstruction of three vessels, circumflex and LAD and right coronary artery. We do the frame counting for the each vessels. In this case, it is LAD. You can see that it is frame was counted, then it is converted to the QFR. So in three vessels, and in this case, three regions, we have a complete analysis of the QFR. So right has a significant drop in QFR 0.67, LAD 0.38. Circumflex was 0.90, so it's not significant. So potentially you can defer the circumflex lesion. But we need a treatment of LAD and the right coronary artery. This is how we do that in the offline in a setting of collapse. So we start to do this analysis of a three vessel. Okay, this is the, we just put the stopwatch of just to see that how long does it take to do this 3D analysis, a three vessel analysis of the QFR. So this is the LAD lesion. I think we had a quite experienced analyst in the quarter, but still it took 5 minutes, 25 seconds for the LAD. We went for the circumflex, and it's the same process. You do the two projection to the analysis. Sometimes you have to correct the edge detection of the software, and then you do this frame count, and then you do the QFR. So in this case, that the circumflex took 10 minutes and 45 seconds because we need to adjust some of the edge detection. And this is the right coronary artery, and I think it's the same process. Maybe we can skip it, but to do the analysis in the three vessel disease takes some time, but in a majority of the time that it doesn't take more than 5 minutes for the each regions. So this is the one of the Japanese center who adopted this QFR and tried to use that during the procedure. So this is QFR during the procedure. It's online analysis. In this case, they have this right coronary artery. You transfer the angio data into this laptop. At that time, it's not instrumented into the system itself, but so you have to transfer the data to the laptop. It's just 2 minutes and 30 seconds, and you do this analysis of two projections of right coronary artery. And I think when we really want to use that in the cath lab, the most important part is to acquire the good angiography with the two projections, 25 degree at least separate each other. So that is really the most important requirement for this angiography. And you see this is now a 3D reconstruction of right coronary artery converted into the QFR. And you see that it's not really a significant QFR. The distal QFR is 0.95. And if you do that, the wire-based FFR, of course, you can do that, but it takes 8 minutes. So QFR took only the 5 minutes. So if we really use this QFR technique very efficiently, potentially you can also reduce the time of the procedure. And as I mentioned that in the Syntax 2 trial, we try to do this QFR in all vessels, but without any instruction on the acquisition, we could only analyze 138 patients out of the 306 for the all regions. In majority of the patients, 168 patients, that we could do the QFR in some of the regions, but not all regions. So if you apply this QFR in multi-vessel disease, it's very important to acquire a good quality of the image, at least 2 projections, and these 2 projections should be at least 25 degree different in terms of projection. There is some kind of a recommendation on the how to take what is the best view for the each vessel or each bifurcation. So I think it is very useful to this kind of the matrix to guide the good acquisition of angiography in especially in multivessel disease. And currently, I think the QFR also has a kind of a simulation component. So if you indicate the region and simulate the residual QFR, that will simulate that if that you treated the one region or two region, what would be the expected QFR after the procedure. And that kind of the function will guide, will be useful to plan the PCI, especially in a complex region or the sequential region or tandem regions. So that is the my part. I think I will give back the floor to Professor Sirais, and Professor will talk about the potential clinical impact of post-procedural QFR.
Yeah, that's a somewhat a novelty. So we are going to terminate this presentation by the few more questions, but this is the first one, the clinical impact of post-procedure. Next. So this is presented by Simone Biscacchia at the EuroPCR 2019, but it has been published in the meantime. It's a so-called OCI study. It's a post-PCI QFR, highly correlate with prognosis. That was the contention and is applicable in most of the cases. So that's very important. We are talking about 751 vessels in 602 patients with a follow-up of about 2 years, 629 days. And you see that if the QFR of your vessel is below 0.89, then you have 25% of event relate to that vessel. That's the new concept of vessel-oriented composite endpoint, VOCE. That's the new concept. Vice versa, if you have a QFR post-procedure which is above 89, and that was done in 628 patients, then your rate of event is extremely low, 3.5%. Now, to pick up that cutoff of 0.89, which is somewhat familiar to us, this is also what had the best predictive accuracy for this vessel-oriented composite endpoint. The area under the curve was 0.77 with a sensitivity and a specificity which are acceptable. Next. So I had the privilege to write an editorial about this OCI system, which is also the system used during on the tennis court in major competition. And this 0.89 is, of course, the binary, the cutoff. You know, in medicine, we always take a cutoff because we are acting as a binary system. The doctor is binary, I do or I don't do. So I have to give a cutoff criteria, 0.89. Next. And this is a good example that a case with right coronary artery and LAD and LCIC, three-vessel disease. Next. And you could see that they put the drug-eluting stent in the proximal right, in the proximal LAD. You could see that maybe they pushed their luck with the drug-eluting stent a little bit too much. You could see that there is a major step up and step down. The circumflex was very nice. Now, what was the QFR after the procedure in this case? 96 for the right, fantastic. 94 for the circ, beautiful, but 0.83 for the QFR. And what happens in the follow-up is next. The right stay okay, no event up to 730 days. The same for the circumflex, but the LAD next developed a restenose, and you could see it's really a edge problem with a proximal narrowing, proximal to the stent, and a distal. So clearly they didn't do a very good job. They oversize and overestimate the dilatation, probably damage the vessel at the edge and get that as a consequence. And that was perceived by the QFR technique. Next. Next slide.
Sorry, Prof, there was some technical problem.
Okay, can happen. So, you know, sometimes computer get blocked. I mean, I'm sure he or she will fix that. If there is a question of, yeah, okay, we go on.
Good.
So basically, that's the kind of data that we have seen by ourselves, is that in the 2 years vessel-oriented composite endpoint, if you use that cutoff criteria, and you know, in our experience, it was a little bit more than 0.89, it was 91, but also we saw something very similar. So we believe in that concept of post-PCI QFR by our proper experience, and I think that 0.89 of 91 doesn't make too much, but we see a clear difference of 12% of event versus 3.7. And again, events strictly relate to the vessel. That's the reason why we call it vessel-oriented composite endpoint. Next. And you see we did classically a multivariate independent predictors in this multi-vessel trial that was the Syntax 2, and certainly the post-PCI QFR below 0.91 has a very strong hazard ratio with a good 95% confidence interval and highly significant. Of course, kidney play a role also. The anatomic syntax score was not emerging. And if you do a second model combining pre-procedural and post-procedural, then you see that again, the post-PCI QFR with a cutoff criteria of 91 increased the risk of late event by a factor 2.45, and it's a significant. For the rest, the other parameter was less significant, of at least overshadowed by the QFR. Next. So post-PCI QFR in Syntax 2, we may say that the higher post-PCI QFR value is associated with improved vessel-related clinical outcome in patients with de novo tri-vessel disease treated with the start of the hard PCI. Don't forget that that was in the Syntax 2. The operator should aim for post-PCI QFR above of around 0.9 in all treated vessels to improve the clinical outcome when treating de novo tri-vessel disease. And these findings require confirmation in future prospective trial with online post-procedural QFR computation according to the specific acquisition guideline. And we will say a few words about the trial that we are going to do with SMT in tri-vessel disease, but I think that Yoshi will end up on that. Next slide. From late loss to QFR, I will not talk specifically about the late loss, but what is important for us is that QFR parameters is a new parameters of device efficiency and is used now for event adjudication in the context of clinical trial. That's very important. We have a few papers on that next. And this is the ARC2, the Academic Research Consortium 2. As you know, I was the senior author of the first version in 2007. That's 13 years ago, basically, with Gottlieb and Greg Stone and Marty Leon and all the academic institutions. Now we have a second version, which has been published and in the European Heart Journal and in circulation. And what is important in the ARC2 is that we will use the QFR to make the adjudication. As you could see, there is in table 7, it is advised to use either IFR or FFR for the adjudication, but of course it's much more easy to do with the QFR. So the ARC2 recommends that resting the PDA, but that's invasive, contrast saline FFR, that's invasive. FFR CT, you need a multi-slide CT scan, but QFR should be used to say that reintervention was justified and not the endeavor of intervention cardiologists deciding to treat a restenosis that didn't need to be retreated. Next slide. Okay, that will be for Yoshi as the last few minutes, and then we will have been talking together with Pendra for just 1 hour, so it will be time for question. Yoshi?
Yes, yeah. So I just would like to introduce this new trial, which is called Multi-Vessel Talent. We will do this trial randomizing the 2 contemporary stent, one supraflex cruise and the versus the everolimus eluting stent in this case synergy, but it is not really the another mid stent versus stent non-inferiority trial, because it will be incorporating the state-of-art PCI in the 3-vessel disease population. So the patient population will be selected based on the syntax 2, and even we are considering to incorporate syntax score 2020, which will be based on the 10 years mortality analysis of the syntax 1 trial. So the heart team will decide whether the patient is suitable for the PCI treatment in a 3-vessel disease. And if the answer is yes, then patient will provide a informed consent, and angiography will be sent to our core-up, and the core-up will do this 3-vessel QFR and feedback to the site. So in the core-up, we will do this kind of the analysis QFR online, and before the procedure, at the time of the randomization, we will provide back to the site all this information, so that as a site, when you do the PCI, you can decide based on the QFR which region should be treated and which region could be deferred. So the site will see this result. Patient will be randomized to the one of the stent arm, and we will optimize the result using the IVAS OCT, and you can also use the QFR post-procedure to guide the post-dilatation optimization of the stent. At follow-up, we try to incorporate the newest antiplatelet therapy, so that the patient will receive the 1 month of a dual antiplatelet therapy, followed by this 11 months of the prascleral monotherapy, which we have demonstrated in the, for example, in the global leaders, the monotherapy has the overall benefit over the standard DAPT in terms of the bleeding without sacrificing the ischemic endpoint, especially in the complex population. So that is the kind of the update of the syntax 2, but this time with the real randomization, and we incorporate all the component of the standard or the state-of-art PCI, syntax 2, contemporary procedure, physiology guidance according to QFR, IVAS guidance, We will use also the contemporary technique for the CTO, and medication after the treatment will be updated DAPT and monotherapy. So this will be now we are trying to start in Europe, mainly in the Europe, this trial, multi-talent trial, and we are finalizing the setup phase. So we expect to enroll the patient in the upcoming months. So I think we have this conclusion slide, Professor, that maybe you could conclude the presentation. Yeah, I think you are on mute, Prof.
We are just 1 hour minus 10 seconds, so I have 10 seconds to read the conclusion. I mean, we did in 60 minutes, very precisely. QFR is a reliable surrogate for invasive wire-based FFR, irrespective of the computational approaches and software packages. Commercially available online QFR and on-site QFR demonstrate feasibility as similar diagnostic accuracy compared to wire-based FFR in the prospective observational trial, and we are waiting for the result of the randomized trial. Using QFR for assessment of functional syntax score is feasible with new version of software. Prediction of post-stenting QFR is feasible, which could guide further the strategy of PCI, stent length, number of stent, etc. In context of clinical trial, angio-derived FFR can be used to evaluate efficacy of coronary device. According to the R2, in the context of clinical trial, QFR could be utilized to adjudicate ischemia-driven revascularization. Impact of both pre- and post-procedure QFR on clinical outcome is under investigation, but we have already good information. Prospective trial it will be done, and if QFR is non-inferior to FFR approach, and or if QFR is superior to angiography guidance, QFR would become the standard very soon. That's it for today. I think that we were just 1 minute above our time, but I'm responsible for that. Upendra, I'm giving you back the floor.
First of all, would be like any other good technique, what are the limitations of QFR? Are there any limitations?
Yoshi, you want to start on that?
Yes, I think the some of the region subset. I think there was also a chat in the conversation. The QFR is not validated in some of the subset of region like saphenous vein graft or the left main, and especially for the left main disease, that it is a bifurcation and it's based on the QCA. So to calculate the QFR in left main region, we need to use some special algorithm by dividing the LAD region and the circumflex region. It is still possible, but I think we need a somewhat arranged method to calculate the FFR in the left main regions. And for the saphenous vein, I think theoretically it should work because there's a no bifurcation, no tapering the vessel. So it's as a modeling, it's very simple approach of inflow and outflow is almost same, so it should work. But I think the validation is still pending in some of the such kind of the region subset.
I think from the physiological point of view, of course, all these angiographic acquisition are made post-nitrate. So basically, you can also do pre-nitrate, there's nothing against that. But I think the principle of FFR and IFR and so is that you have eliminate the component of vasomotion. And certainly the vasomotion is something which is part of the physiopathology of angina. So I recently saw one paper on QFR post-ergonovin and pre-ergonovin, and certainly it's something that could be had if you suspect a vasospastic component. Myself in the past, unfortunately, I never published that. I did FFR without nitrate, followed by ergonovin and FFR, and then ergonovin, nitrate, and FFR. And of course, there are major differences. So that's something which is still a field of possible investigation.
Okay, thanks. What about the patients who have a grossly irregular rhythm, atrial fibrillation and frequent ventricular ectopics? Does it matter? Does it interfere?
Yoshi, go first. You mute.
I think basically that doesn't matter too much, at least as long as you can really see the diastolic phase on angiography. And I think the best is to have a biplane so that you can really see two projections at the same time and at the diastolic phase. Then I think that's the best. But if you have a monoplane, then you have a kind of a same phase on two different projections. It's important to have a diastolic phase, but as long as the diastolic phase in the two projections is available, I think QFR is a very reproducible and robust method to calculate functionality of the lesion.
Nothing to add.
Okay. Now, most of the work which has been done and what we are talking is that the frame rate should be 12.5. Now, there are labs which work on 7.5 and 10 frames. So is it a limitation, or you can modify something or do it?
Go ahead.
So I think that's the it's difficult to answer, but I think it's good to have a relatively high frame rate so that we can really capture the diastolic phase, and it's also increase the kind of the temporal resolution of angiography. So we always recommend a frame rate of 12.5 frame per second if possible, but of course if the site is using 7.5 or the frame rate less than 10, we can still use and analyze this QFR. It's basically based on the QFR. It's just to increase the quality.
Yeah, I think that the generation of Upendra and myself, we start initially with 50 frames per second in the lab, and then went to 25, and then went to 12.5. Now you want to go to 7.5. Finally, it will be a still frame also. So that's a joke. But I think that we have to think a little bit the cost benefit for the patient. If the 12.5 is somewhat more precise and accurate than the 7.5, and it must be in some way, then we have to consider that the decision to treat a lesion or not to treat a lesion is probably at that moment more important than the number of frames per second. I think that's the kind of cost effectiveness, risk benefit, which is very important. Yeah.
Like in some situations while doing FFR, we get an FFR of 0.81, 0.79, repeat it, it's the same. So is there something like a gray zone, where you have to do something, or you like to do a FFR in those situations? Or
yeah, I think that, as I said, the doctor like to be binary. I mean, he like to have one number in his head. Above that number is good, below that number is bad. That's the human nature, okay? Now, there is an element of good judgment here. Basically, in the syntax 2, we work with a gray zone. The gray zone at that time was 8693. That was the gray zone in which we had to do in FFR on top of the IFR. But obviously, during that trial, Flair and Sweetheart came up with one cutoff criteria and a clear answer for outcome. Having said that, and I said also that we should not neglect the component of vasomotion. And what you see in the lab with an 84 of a 91 and a 92 can be probably different with vasomotion. I think that's a question which is not resolved. I don't think that there is a real gray zone today. I think that the value of, let's say, 0.9 is very solid, but you know, it's the good clinical judgment. Therefore, we are doctors. I mean, you have to take a decision. But that's the reason why I show that slide on the court, you know, with the OKI system. When the ball is just on 0.89, what do you do? I mean, there's no response to that. I mean, as I said, personally, the only thing that I could modify is the vasomotion. That's the reason why in the past I was doing the FFR with or without ergonovin, with or without nitrate, when I could not understand clearly the pathology of the patient. And of course, you enter the whole field of does the angina pectoris comes from the microcirculation? We are not addressing that question. I mean, and that's really the dark side of the physiology today, because not only we are not interrogating that, I mean, it's much more difficult to interrogate. You need the microvascular index. It's a much more complex assessment, but also we have no treatment for that. I mean, there is no specific drug for microcirculation, and we know that the diabetes have that. And it's in the majority of the case non-reversible, unfortunately. So I think that drugs will maybe address that things in the future, but medicine is not simple. So we will always have to decide what to do on top of a number. We are not machine, and it's not the computer which is deciding for us what to do.
What about bifurcation lesions? What is the utility in bifurcation lesions? Can we get confused?
Yoshi.
Yes, yeah. So when we did this analysis of syntax 2 trial, we also looked into the correctness of the measurement versus the wire-based measurement. And one of the predictor that to have an incorrect QFR measurement was a small vessel and the lesion in the side branches. So I think bifurcation lesion is still somewhat limitation of this technology, especially if the lesion is present at small side branch. That the reason is the probably the calculation of reference vessel, as like in the QFR, there's a natural tapering of the vessel. If you go into this bifurcation lesion, especially in the side branch, there's a kind of a tapering of a lesion, natural tapering. It's not a lesion, but you do the a straightforward analysis of the QCA. The proximal part is large, and if you go to the side branch, the reference vessel becomes very small, but the computer will generate some kind of the pseudo stenosis in the side branch because of this tapering. That's probably confused the algorithm of QFR. There was some kind of solution to divide the proximal part of the measurement versus the distal part of the measurement. So you do the 2 times the QFR proximal part and distal part, and you can multiply the QFR of proximal part and distal part. Then you have a kind of a solution, but I think it's a little bit too complex to do that in the clinical situation. I think in the Cora we can afford to do this kind of the sophisticated time-consuming analysis, but I think in the clinical situation still there was a room for improvement for the algorithm to be applied to the bifurcation lesions.
But we have been working, but that was in a combination of IVUS and angiography on what happens at the site of the bifurcation. And of course, we cannot neglect the basic concept of fractal division of the flow that's there. So I think that clearly on Schreiber with Madis, two in Shanghai, both are working on how can we integrate in the next generation the fractal concept. I think it will come. I'm also puzzled by the fact that if you look at the analysis of cat work, I mean, clearly they are in some way considering the bifurcation, but I really ignore how they are doing that.
What about, a bifurcation where the side branch looked all right, row was all right, you stent it, and now angiographically you feel that, it has been compromised or pinched. What will be the utility at that stage? Like we use FFR quite often for these situations. Yeah.
Yeah, the Antonio Colombo used to say, if you see pinging after treatment of the main vessel, pinging of the side branch, is that because you should make more angiographic view. So what he means by that is that pinging effect is in many cases due to an elliptical shape of the image. So it's true that in the past with OCT, we have made these analysis of the pinch effect. And we discovered that some of the pinching effect was due more to an elliptical shape, but the lumen area was very substantial. And that's the reason why we could not find a pressure gradient in the side branch despite the pinching effect. So I think it's possible that the IFR will be able to say, okay, it's something very focal, point number one, and it's elliptical, yeah, because you are doing two projection. So you may disclose the elliptical aspect of the lesion, and then probably the FFR will be negative in this case. But that's a field that clearly has to be explored.
Now coming to the post-procedure QFR, and if it is more than 0.9, 0.91, we'll be happy. Suppose the angiographically it looks fine, and it is 0.86. So what do? Do you recommend imaging because you didn't done 2 views, 3 views, you feel it is all right. You're not sure what to do, but your FFR, this QFR is clearly showing that it is suboptimal.
Okay, maybe I'll take first here. I think my position is that physiology is the ultimate response. I mean, if you got enough flow, if you have no gradient, whatever how it looks, it's okay, because the physiology is the resultant of the anatomy. I mean, that's point number one. I think that if I had that kind of value before doing something more to that lesion, I would like to try to understand the anatomic substrate. So that will be a reason for me to do an OCT and an IVUS to say, what are we facing here? Are we facing an under expansion? Are we facing an edge problem? Are we facing something intraluminal like a prolapse? And so that's what I would try to do before going back to the lesion and blowing again the lesion. I would try to understand, to have what is the mechanistic factor responsible for that. Yeah.
Yeah, and I
Yoshi,
think
different view?
no, I just pointed out it's important to look into this curve of a QFR in such cases that if the gradient is present in the stent, maybe it was to do the post-dilatation, but if it is outside of stent, then we have to really think about the to add an additional stent, or if it is because of diffuse disease, then probably there's no means by PCI to improve this post QFR. So it really depends on where the QFR drop is coming from.
What about rheology of the blood? You know, hypercoagulable states, anemia, flows can change because of these things. So does it pose any challenge or?
I think that the rheology, as you call it, is very important. I mean, just the viscosity of the blood is something very, very important. So anemia or play a role. I think it's beyond, it's a sophistication beyond the practical instrument that we have. We have been doing very complex things on shear stress, where obviously the viscosity of the blood is playing a role, but here we are not taking into account that factors. It's really a practical technique beyond the below the sophistication of looking at viscosity, density, and we have done that. I mean, it certainly plays a role, you're right, but so far we have not found a way to incorporate that, and to what extent it plays a role, we don't know.
Yoshi, you have to add something on this?
No additional comment.
So now let us come to situations of acute coronary syndrome and maybe acute MI with multi-vessel disease. We've done the primary, the culprit listen, and we have enough time. And other vessels are also showing intermediate lesions. So what do you recommend in these patients? Is it equally reliable in these situations?
Maybe I'll start, and I'm sure Yoshi will have a lot of comment. I'll start because I'm puzzled. I'm puzzled because you have, for instance, in the New England, the study of Peter Smith compare acute, okay, where he used the pressure wire. Are you still online there? Yeah. Where Peter Smith in compare acute was using the pressure wire to guide the intervention, and he clearly showed that it was important in terms of outcome. On the other hand, you have the big American study called COMPLETE, where it was visual, and they came to the same conclusion guided by visual. So that's my personally concern. I mean, I'm not so sure that I understand the field right now. I think that clearly the QFR will be easy because, again, in acute myocardial infarction, to start in the middle of the night to do a pressure wire, to have the technician taking care that there is no shift, no drift, etc., etc. I think that you will have at the end of your primary PCI quite good coronary angiography, because we are always looking at both vessels prior or after the recanalization. And I think the next day you will have the possibility to make your analysis. The patient will be still in the lab. And I would give the more than the benefit of the doubt in favor of Peter Smith. I think that even in acute coronary syndrome, the physiology of the other vessel is still valid. That has been demonstrated. And I think it's still a good guidance to say, okay, okay, that's lesion is not the culprit, but has to be treated because it's ischemic related, it's flow limiting. Anything to add, Yoshi?
Yeah, I think there was a couple of publications on the non-culprit lesion of the QFR assessment of the non-culprit lesion in the setting of acute coronary syndrome. One of them I published in the SAC intervention maybe 2 years ago from the group of Dr. Campo. And I think they, it was really not big cohort, but the kind of the proof of concept type of the study, but in the limited selected population, they have demonstrated that if you stratify the patient according to the QFR value of the non-culprit lesion, then they clearly see that the worst outcome if the patient has QFR less than 0.8 in the non-culprit region. So that's one piece of the information we have in that kind of situation. And I think, yeah, theoretically, as long as the flow is not impaired, a QFR should be able to apply to the non-culprit lesion in a setting of acute coronary syndrome. When it comes to the FFR, post-FFR, post-procedure QFR in the culprit lesion, there might be some consideration about the impaired flow because the in the algorithm of QFR, there was a component of the frame count, so that if the frame count is influenced by the myocardial infarction or the plaque rupture, so maybe that might influence the calculation of QFR in the culprit lesion.
We've been talking about coronary arteries, which are very important, but what about its utility in carotids, renals? We do see, you know, intermediate lesions there. So should be, you know, logically useful, but is there any data?
Yoshi?
Yeah, so as long as we know that we haven't seen any data on such applications, and I think the QFR is based on some assumptions in terms of the inflow and outflow, and I think it's based on the kind of the flow, flow in, flow out, and that's the important for the modeling of QFR calculation because it's based on a 3D modeling. So if the inflow and outflow of carotid or the renal artery is different from coronary, maybe I think the algorithm should be adapted for that situation.
Okay. I'm looking for our friends to ask some more questions. Well, we discussed that stability of rhythm is not a problem. Stability of hemodynamics is not much of a problem as long as you can do, you know, two views 25 degrees apart. Frame rate is all right. You know, you can always do it in, you know, smaller frame rates. And any other, you know, burning points you want to tell us which you think we missed in your, you know, practice? Yeah.
Yeah, no, I think no, we don't have so much things to add. I think it's good to probably try to use that online. I think you know, to take a good projection without overlap and with a good depiction of lesion is sometimes challenging, so that I think it's important to just acknowledge that to take a good projection, two projection image without overlap, without foreshortening is very important.
Well, if you're doing an angioplasty and using a, you know, relatively bigger guiding catheter and injecting through that, does the pressure damping result in some erroneous readings?
You mean the big guiding
Yeah,
catheter
French
might.
guiding catheter and, you know, 8 French guiding catheter, you completed the procedure, or you're looking at other vessels, you don't want to change the guiding catheter, and you take a picture and flow might be not the same as when you're doing with an angiography catheter? Will it make
Yeah.
a difference in the assessment?
Yeah, by definition, yes, I would say that if you have a damping of your signal is because you are partially obstructing the ostium of your vessel. It was a big issue and it's still a big issue with IFR, FFR. You cannot have an aortic signal which is damped. In the FFR, that's not going to play a role, but what is going to play a role potentially is the frame count. Now, if your damping is such that you affect your frame count, then you may have erroneous data. But you know, you really have to completely obstruct your coronary artery to have a major effect on the frame count. Yeah.
What about ectatic vessels? When you're doing angios in ectatic vessels, you have slow flow and other things.
Yeah. This
Diastics
is
there.
Yeah, that's very, very complicated. I mean, I would be the first to say that. I mean, we have been analyzing shear stress in aneurysm. It's something which is very difficult. We are doing now a lot of work in animal on bypass graft, okay, comparing a graft in bioresorbable material, believe me or not, graft in bioresorbable material. And we are comparing with the vein, with the saphenous vein graft of the vein. And Yoshi can comment on that, but we have seen QFR in these ectatic, not necessarily ectatic vein, but vein which are clearly affected by remodeling because you put a vein in a circulation under a pressure, a systemic pressure, and you see this vein in the animal getting dilated and becoming a big sausage on the coronary artery. And we got some funny result of the QFR in these over-dilated saphenous vein grafts. So that's something we are not yet fully understanding, yeah?
Anything in special situations like acute MI, PTCA getting no flow and then the flow starts coming back, and does it give any guidance that the flow is sufficient now? Wind up.
Yoshi, that's becoming more and more complex.
Yes, yeah, but I think basically if the flow is impaired during the primary PCI, probably it will also influence the measurement of the QFR because flow measurement will not be the correct one. So I think QFR in the culprit vessel might be somewhat influenced by the such phenomenon of the no reflow or the and I think that basically this QFR is not completely replacing the wire-based measurement, but it's initially to facilitate the physiological assessment before procedure. So I think if there's any doubt or any things which you think that it will influence the simulation, then I think it's good to consider the wire-based approach as well, and just to make sure that we do the good measurement on the physiological assessment.
Coming to in-stent restenosis, and it presents in many ways, and if you have a stenosis which is intermediate in in-stent restenosis and you don't have a thallium or some such thing, you just detect it. So any relation to this? Yeah.
I will take that one. I think we have good data on in-stent restenosis. Basically, in the CE mark approval of a Chinese stent of Sinomed, we used that technique over the last 2 years for the in-stent restenosis. And in-stent restenosis is a very peculiar animals, I would say, in the sense that most of the time the entrance angle and the exit angles, with the exception of the edge, is quite reasonable. That's point number one. Point number two, the neointimal tissue gave a pretty soft and uniform surface in most of the case. Of course, there are asymmetric lesion. You can use the Meran classification for restenosis. But in our experience, the QFR worked very, very well for the instant restenosis. We have made a curve of comparing late loss and QFR. And obviously, you may have a late loss up to 0.3 or 0.35, 0.4. The cutoff criteria for us was 45, 50. But below that value, it does not affect the QFR. So it's there visually, you can quantify that in the late loss, but it has no impact. Maybe Yoshi, if he can show one curve, because that's really, I don't know if he can quickly find the data on the instant restenosis and the QFR, but it was very useful. And that's also the reason why at the very late moment, when we were publishing in Circulation in the European Heart Journal, the ARC2, I mean, one is a lesion clinically indicate, we introduced the QFR because we had good data on that.
So in the meantime, while Yoshi is trying to locate that slide, let me just ask, can this method help us in choosing the device, like drug-eluting balloon versus a stent in some situations, looking at the size, looking at the flow, looking at, some other variables?
Yeah, I think the illustration, the publication is a little bit more complicated than what you're seeing on the slide, but this is a typical example of you could see how many lesions are below a QFR of 0.8. And at that time, we were comparing the BUMA stent with the Resolute stent. And you could see that although there was more loss, significantly more loss in the BUMA, in terms of physiology based on QFR, there was no difference. So basically, the late loss, something that I have created, my gosh, I almost regret today, is that the late loss is not the ultimate criteria to judge restenosis. No, it's the physiology. So you were asking a very, very good question, a very important question. Yeah.
Yeah, I was asking about whether the choice of the device, drug-eluting balloon versus a stent or something else, can be, the method can help us in choosing that depending on the size of the vessel, flow of the vessel.
So I think the in a QFR there was a function to predict the post-procedural QFR, and as we have shown that there was also the information on the diameter of the analyzed vessel. So that will be help to plan the procedures, especially if it comes to the sequential lesions or the tandem lesions. Either if you put the 2 stent or the 1 stent, or 1 stent versus the one a drug-coated balloon, and you can really plan that with the information of the diameter. So I think that's probably the way to somewhat plan the procedure accurately according to the information obtained from the coronary angiography. So yeah, I just show the again share this slide So if you look at this slide, that in the software you can see the diameter of the vessel, so you can really see or select a device according to the diameter of the vessel. If it is too small, maybe we go for the drug-coated balloon instead of the stent. If it is enough diameter, you can select the drug-eluting stent, and it also depends on the QFR drops, that where the significant drop occurs is very important. And maybe, for example, in this case, if you just treated the from here to the 40 millimeter, you might get FFR value of maybe you will improve 0.2 or 0.21, but ultimately probably you will still have some significant QFR in the distal part. So in this case, the treatment of this part is not enough. I think you should stent from this in between the green line. So, and in this case, that there was enough diameter of the distal part so that the entire segment was treated by the drug-eluting stent. But I think those type of the information, diameter, geometry, and the drop of the QFR will help the operator to plan the procedure very precisely.
Yeah, I think the only thing, because Ipendra was alluding to drug coating balloon, I think that the last major paper on drug coating balloon is insisting on the long-term follow-up. And as Yoshi said, I mean, it's the QFR and the angiography and all the matrix provided by the technique is very useful to select the type of balloon, the type of stent, the length of the balloon, the length of stent. But of course, it's an acute judgment. What is very important is the long-term follow-up. And I think I was puzzled by the paper in JACC intervention by Giovanna Sarno, which is one of our ex-fellow. She looked in SCAR on the drug coating balloon, and they had something like 1,150 drug coating balloon versus 14,000 drug eluting stent. And I discovered the paper with some surprise, because in SCAR, the drug coating balloon was doing less well than the drug eluting stent in the long term. That was not what I was expecting. But I think, like good interventional cardiologist, I think one, we have eliminate transiently or permanently, but when we have eliminated the flow limiting factors, we have to work on the disease. That's the problem. We cannot say, I've done my job, now we have to think about treating the diabetes, giving the statin, maybe in the future giving PCSK9 medication. It's an entry in the disease, it's an event, but then you need really to work very hard on the secondary prevention. Otherwise, what you do, despite all your measurement and all the device, will not be sufficient. So I was puzzled by these paper that I strongly recommend on percutaneous treatment and outcome of small coronary vessel, the SCAR study, drug coating balloon versus stent. Yeah.
Now coming to the type of stents, now we're talking a lot about ultra low strut thickness stents, and SMT does a lot of work in that. And does this technique help us in comparing stent versus stent, ultra low versus not so thin stents, by studying the flow parameters and any other parameters through this technique?
Can you rephrase your question, because I think there's two components here in your question.
Ultra low thickness stents, that is less than 70 versus more than 70, say Zion's 80, 85. Can the characteristics of the stents be differentiated in a meaningful way by this study, by this technique?
Yeah, let me let me say a few things which are not yet published, but I hope it will be published. And then I tried to respond your question. Recently, with the group, we have done a meta-analysis. We have done a meta-analysis of the ultra-thin stent, the 60 micron, let's say. And we have basically 4 of them, and we have currently the 2 years follow-up, okay? And one of the 4 stent is the flex stent of SMT. And we came to the conclusion in this meta-analysis that really the 60 micron was even superior to the Xience 80 micron. So that's a piece of information that I'm giving you before the paper is submitted and published, so we will have to see. Now the question is, what is the interaction between the ultra-thin and that technique of QFR? That was a little bit the second part of your question. I have to think about it.
Okay. No.
Maybe Yoshi has an idea. Maybe we should ask Yoshi if he has an idea.
Yeah, no, I think, no, I don't have any additional answers.
Something to work on.
Yes.
Work in progress.
Work in progress. Let's put it that way.
Now, the other thing is that the kind of contrast we use in the cath labs, isoosmolar and, Hexabex and Visipac, and does it make any difference? Or should we be using the same contrast for follow-ups and other things?
Yoshi?
Also.
Yeah, I think theoretically yes, but we don't know how much it will influence, and so I think in terms of the measurement and reproducibility of the measurement, I think probably it's good to have a same condition and same contrast, but we still do not know how much it will influence on the QFR. But yeah, if we have a angiographic primary endpoint study, like a retro study, that definitely I think it's good to have same condition of cath lab setting, like including the contrast agent and the way of injecting the contrast at baseline and follow-up.
Yeah, it's always the same. I mean, it's a little bit connect to your question of viscosity, anemia, and so. I think the technique has appeared, as we have shown, in 2014. So we are in the 6 years of the technique, and you can be sure that around the world there will people will do that kind of analysis. Anemia, viscosity, contrast. I think all this information still has to come. Yeah, once it is, it became something used by Mr. Everybody. There will be a lot of additional information, positive, negative, about we overlooked this in the past. I'm sure about that. I'm sure. Your questions are very good because they are stimulating potentially research, ideas, and so. And but right now, as Yoshi said, we don't have the information. Yeah.
So then the final question is that what do you think is the future of QFR? Is it going to replace invasive wire putting in methods?
Let's the young generation should talk first.
Yeah, no, I think if we answer very shortly, it is yes, I think, because it makes sense that we can do this physiological assessment simply without pushing the wire into the lesion. The only challenge is, I think, really the acquisition of the angiography, and it's very important to have two separate projections. So whenever you see the intermediate lesion or some sort of the lesion on the angiography, we should bear in mind that to take a good two projections, but it really simplify and the procedure itself, and also the reduce the cost of the procedure, because we don't need the wire to investigate the physiological importance of the lesion. And if it is incorporated very well, we can do that online, so that it will not really disturb the catheter flow once we can install that software in the online analysis of the catheter. So I think it will change the catheter practice, and I think it will eventually replace wire-based physiological assessment. That's my personal opinion.
Okay, I'll give mine. No, I think you're right. I mean, again, as Yoshi, if you need a short answer, I think today the short answer is yes. But I would say that I see the whole thing in a continuum. You know, I'm a great proponent of having the multi-slide CT scan as a first approach. It's a question of time. First approach, just to say the anatomy is normal or abnormal. Then you have the FFR CT, which is somewhat the father of the FFR QFR. I mean, I showed that on my slide, it was there in 2010. And we came to, hey, can we do the same with the angiography in 2014? So I think that the multi-slide CT scan will be the first line of diagnosis. You may have an FFR CT. You go the next day in the cath lab, you know the projection that you have to use because you have seen in 3D from the multi-slide CT scan. So you know in which view you have to film. If you find at that moment a QFR which is completely compatible with your FFR CT, I think you will you will go forward to treat or not to treat that lesion. If there is a discordance at that moment, okay, between your FFR CT and your QFR, probably you will escalate and you will say, okay, let's go back to the good old pressure Y, if I still have in the lab, and use it. And then in addition to that, I mean, if that patient who had clearly angina and doesn't show stenotic lesion, then I have this problem of microcirculation. And the problem of microcirculation can only be resolved by a combination of pressure Y and velocity Y if you really want to make a diagnosis in this patient. And I mentioned the fact that we cannot treat today the microvasculature, but I'm sure that in India you have plenty of diabetic patients who goes on the table. There is no clear epicardial lesion, but nevertheless they have angina pectoris. So I think it's a continuum. I think it's a good workhouse between the sophisticated analysis, you know, an acetylcholine infusion, measuring the velocity, which is for the case that we don't understand. It's a good workhouse between the non-invasive imaging of the multi-slide CT scan and the sophisticated technique. Yeah, certainly.
Great. And finally, we're in the COVID era and we have to discuss small point about the COVID. Do you think in this era, which is going to last, we already have more than 250,000 patients who have tested positive with more than 6,000 deaths in our country. So do you think in this era, this technique is going to help in reducing the number of people in the cath lab?
I'll take that one, Yoshi. So first of all, it's interesting. Today at 5 o'clock, you will see the embargo is finished on a paper where Yoshi, myself, William Waynes are involved, or fellows were in Galway and went back to China. With these fellows, we have a fast-track paper in the European Heart Journal on COVID in 3,000 patients. The patient who get in this Wuhan hospital on February 5th, and we follow on until April the 1st. So we have been very much involved directly and indirectly with the COVID. Now, the question that you are asking is that there is, of course, a new literature about even ST elevation and no culprit lesion. That's point number one. Point number two, that virus is certainly affecting the endothelium, and thus there is a thrombotic component, certainly very, very strong. And the third point, there is also a myocardium, in fact. The myocarditis is playing a role. I mean, every Monday with Tom Lucia, John Cam, and Gerald Maurer for the textbook of the European cardiology, we are working together, and we are building up very quickly on a COVID chapter. But I think that the myocardium component with the troponin release, the thrombotic aspect, and nobody has been talking about vasomotion, but I'm sure it will be there. I still, right now, I don't see the connection between the QFR and that. I cannot do that. When I saw on the upper screen that somebody was asking a question on the COVID, I said, is Upendra going to raise that question? And you did, but I don't think we have an answer. We're just trying to understand all the components of this virus infection on the cardiovascular system, and I think they are huge.
Well, thank you very much. I think we had a very
Dr. Kaul.
Yeah.
Dr. Kaul, in fact, in the era of COVID-1 and MERS, we had this observation endothelial dysfunction, slow flow, and hypercoagulable state in cardiogenic shock. We did a lot of research, as we discussed earlier also. So this was our approach, and we are advocating to the whole world that fibrinolytic therapy followed by 2B3 inhibitor. After this, all patients recovered in PGI, COVID, and they became negative also by giving albumin and other things. So presently, we are advocating in COVID era to CSI, to others also in all webinars, that COVID era should be treated. And of course, this QFR will be very valuable because there is no pressure wire should be put in. So I put this in this chat also. So that is important. In fact, very informative lecture, and you conducted very nicely. Thank you.
Thank you, Dr. Yashpal. So I must thank our guest, Professor Sarayas, and my friend, Professor Yoshi, for spending 2 full hours with us. I think we have a large audience today, and we discussed on the subject, a very important subject of quantitative flow ratio, which I think is a very promising and futuristic method. It's slowly permeating into India. I think we have got 3 or 4 labs which already have it. And the advantages are quite obvious. You get a lot of information without putting in a wire, and physiological estimation of the lesions, especially the intermediate lesions, continues to be very important. And not only that, it also gives us, the residual QFR in terms of whether our job is complete or not. And we had many thought-provoking questions, and I think we need to learn much more about it. But I think it's a wonderful technique. And now that we have started our Tuxedo 2 study, which is already started, it came a bit slow because of COVID. I think we're going to incorporate this also in all the labs where we already have it as a part of evaluation of the patient, because they're all diabetic patients. This is 1,800 patients of diabetes, and in that, I think this might give us some further insights about the flows, because as Professor Sarai was saying, the endothelial function and the myocardium getting into those issues of perfusion is maybe better delineated by this. I can't say what will we find and what is our hypothesis. But I think we will encourage our people who have this to QFR also liberally these patients in as a separate column, write it down there. And finally, I think we might get some information which would be worth sharing with all our colleagues internationally.
Would like to thank you because really
Yes.
you did a wonderful job as a host, asking the right question. We would like to thank the SMT because what they did is really of great value from the point of view of educational point of view. I think that I'm speaking for Yoshi and myself. It was very exciting for us because you raised so many questions that probably tonight we will not be able to sleep, and we will think about all the questions that you have raised, and we have to resolve. So on behalf of Yoshi Onomai and myself, I really thanks everybody to have organized that event. Yeah.
Thank you. Thank you. Pawan?
Thank you very much.
Bye-bye.
Yes, yes.
Yeah. Thank you.
So on behalf of SMT, we would like to thank our eminent speakers, Dr. Patrick, Dr. Kaul, and Dr. Yoshi. Secondly, we would like to thank our wonderful audience. So they took time on this Saturday evening. Third, we would like to also thank our partners, NADIS and GE team. And last but not the least, we also thank our sales and marketing team of SMT who helped us to arrange this kind of webinar. With this, we would like to just wish a happy weekend to everyone. Thank you so much.
Thank you very much.
Bye.
Bye-bye.
Yeah. Thank you very much. Bye bye.